Okay. Yes, sir.
Yes. Yes, sir. It's a very good evening to all. My case is also similar like Pudukkottai and Salem GH cases. The capillary leak syndrome following the Russell Viper envenomation. The Russell Viper is known as neurotoxic and hemotoxic effects. Rarely it causes capillary leak syndrome. It is characterized by hypotension, hemoconcentration, hypovolemia, and edema. Our case is 36 years old female, alleged to have snake bite at left foot, presenting complaints, blood vision, bilateral ptosis, hematuria, swelling and pain in the bite site. Initial assessment, vital stable, local swelling is present, bilateral ptosis present, other system normal, WBCT more than 20 minutes. Blood test normal, urine analysis plenty of RBCs. Initial management 30 vials of AAC given for neurotoxicity, hemotoxicity, local cellulitis, supportive care, IV fluids, IV antibiotics given, other supportive measures given. At 24 hours, the hematocrit 37, platelet 2.5 lakhs, urine output reduced at 800 ml per day, urea 60, creatinine 1.5, INR 1, WBCT more than 20 minutes after 30 vials of ASP. That's like previous case. So after 48 hours, so patient developed tachycardia, periorbital edema, parotid swelling, oliguria, hypotension, reduced SpO2, increased heart rate. The patient has periorbital swelling also there. Periorbital swelling also there. So 48 hours, hematocrit 49, raised, platelet reduced 55,000, urine output reduced 400 ml per day, urea 99, creatinine 4.5, drastically reduced at 24 hours. INR 1.68, WBCT still more than 20 minutes. So increased hematocrit, reduced platelets, hypovolemia, hyperkalemia, ultrasound shows minimal ascites, bilateral pleural effusion. So clinical suspicion based on edema, hypotension, hemoconcentration, hypovolemia, evidence of third spacing, pleural effusion. Rare but known complication of is capillary leak syndrome. Started inotropics, nasal oxygen, FOP 4 units given, hemodialysis 2 sessions done. After that, improved urine output, stable vitals, lab investigation normal, resolution of edema, parotid swelling, local cellulitis was noted. So hematocrit after hemodialysis 36, platelet 1.96, urine output 1800 ml, urea 25, creatinine 1.2, INR 1, the WBCT less than 20 minutes. So conclusion, capillary leak syndrome is a rare but serious complication Russell Viper envenomation. Early recognition, aggressive supportive care is essential. Hemodialysis and FOB may be beneficial. High index suspicion is required for deteriorating patient with post ASP after 30 vials of ASPs. Similar case like the Salem case.
Actually, this patient also had a neurotoxic.
Yes, sir, neurotoxic.
So that is another area we have to, even though we traditionally say crates and cobras are neurotoxic and vipers are thing, I think this overlap syndrome is very common in our practice. Yes. So especially when we are sensitizing our primary healthcare doctors, they should be also taught that there's a lot of overlap syndromes in our practice. Yes, sir.
Thank you, sir.
Thank you. Only one case only, no, sir?
Yes, one case.
Thank you, sir. Yes.
In this patient, initially the renal parameter seems to be okay on the first day and second day. Yes, sir. So like these patients, as we have seen in dengue-like picture, so before the capillary leak presentation, how was the hydration managed for the first 2 days? That also have a better role on the renal management. Whether that if it is taken care of that hematocrit rise, everything, if it is occurred after that adequate hydration management, then it is okay. The first 2 days, the fluid management also plays an important role in this.
So before we request the next speaker, because from morning we have not discussed about the sea snakes. Anybody in the audience have managed any sea snake envenomation? Okay, so in our Rajiv Gandhi hospital, we had around 6 cases of sea snake envenomation. The first case was a fisherman who was fishing in the sea. In the net, along with the fishes, he saw the sea snake. So when he was trying to put it back, it was bitten and he was admitted. And in fact, when he came to our hospital, he presented with neurotoxicity, with bilateral ptosis, with respiratory paralysis. So that was our first experience also. So when we referred the literature, normally we know sea snakes are notorious to cause rhabdomyolysis, myotoxic, but literature says it can be neurotoxic also. So we managed that case with ventilation, and he had some rhabdomyolysis and myocarditis also. He had some enzymes were elevated. So in fact, that case was well managed by Dr. Sendil and got published in AP. So why I'm telling is, subsequently to that, we had 3-4 cases, and 2 people were bathing in the sea near Kovalam beach. There was no history of bite at all, but they had a bath in the sea for more than 2 hours. After going home, they had a severe muscle pain with myoglobinuria. So they didn't know what is due to. They went to a PSC and they thought something else and they referred to us. But again, that's why the history of bathing in the sea in the evening and going back and developing severe muscle pain and rhabdomyolysis, and we used FAD cycles for those cases and record. Yes, before we next case.